Welcome to the Learning Lab. My name is Roman Garcia. In this volume, we're going to be discussing a ligament that exists in the knee joint that's one of the more commonly torn or damaged ligaments in the knee joint. It's called the anterior cruciate ligament. Now, but before we go into the anatomy, how to examine it clinically, and some examples of what is done orthopedically once a ligament is torn and how it's reconstructed, I want to go through a formula that we discussed in our last video. And the reason I want to go through it is because I want to make sure that you understand this formula clearly, because it has a relevance insofar as any time that you have an anatomical change in the joint due to a trauma. And this anterior cruciate tears, it is one of those traumas that the knee joint gets exposed to a changing of its environment. Now, I just want to go through this formula real quickly, because there's one variable in this formula that is affected when the anterior cruciate ligament is torn. Now, for anybody that saw our last video, they're familiarized themselves with this formula. Now, VP, P means phenotype. All that is, that's just a fancy word that means the structure or the form of the joint. The structure or the form of the joint is summed from the hereditary of the individual, the environment, and a chance occurrence. Now, when your ACL or when an ACL gets torn, the variable that changes in this formula is the environment. And I'll show you in a little while why that is so and what exactly changes in the knee joint itself. But I want to just go through real quickly just the anatomy so you get an idea where the anterior cruciate ligament is. This is a very simplistic representation of the knee. It's not accurate anatomically, but the most important part of this picture is the orientation of the anterior cruciate ligament, which you need to understand the alignment so you know if you decide, or if your ACL gets torn and you decide to have it reconstructed, the angle that the anterior cruciate ligament takes is very important for you to understand if you're undergoing this reconstruction, because it makes all the difference on how well you respond to the surgery. Now, this diagram right here is of the left knee. This is the left knee. This is the inside. This is the outside of the knee. Now, this is the anterior cruciate ligament. This is the anterior cruciate ligament. Now, you can see its orientation. It comes from the inside to the outside of the joint. Remember, this is the left knee. So the orientation of the ACL is angled upward, going towards the outside. You can see how the angle is. It goes from inside to outside. This is very important. You need to understand the angulation of this ligament, because it is the basis of a successful or unsuccessful surgery. Now, what I did here is so you can see a actual organic example of the ACL. These are bones from a chicken. Now, the interesting thing is that the anterior cruciate ligament of the chicken is oriented in a very similar fashion as a human knee joint. Now, what I did is I put a little bit of color on it so you can appreciate where the ACL is. It's right here. This is it. Let's assume this is the left leg of the chicken, or the knee joint of the chicken, which it probably is because of the orientation of the ACL. Now, you can see it in red right here. You can see it's in between the bones. This is representative of the thigh bone. This is representative of the knee bone. Right? You can see the color right here. This is the ACL joint. Now, interesting enough, I'm going to turn it to the side. This is the inside. This right here, this is also a ligament that is inside the human knee. This is the medial collateral ligament, but we're going to be discussing today just the ACL, which is right here, right in between the femur bone and the tibia bone. I'll show you on my test model where exactly you would find it and where it's oriented. But as you can see, the ACL does the same thing in a chicken as it does in a human. It prevents, I'm going to turn it out to the side, it prevents the upper bone and the lower bone from moving too much relative to each other, forward and backwards. You can see there's a tension there. That's what the ACL does. It prevents the lower bone from moving too forward on the upper bone, and vice versa. It prevents the upper bone from moving too forward on the lower bone. You can see there's some tension there. It does the same thing in a chicken as it does in a human. It prevents forward and backward gliding of the knee joint. Basically, it gives stability to the knee joint. Now, we're going to come back to this in a little while. But what I'm going to do now is I'm going to show you clinically how the ACL is examined in a clinical situation with the help of my model, Anna. Now, there are many tests, orthopedic tests, to examine the anterior cruciate ligament. A clinician does not need to do all of them in the books, but he cannot rely on just one. In order to determine whether an ACL is torn or not on a patient, you really need to do 2 or 3 of them, and then create a synergy of your diagnosis part based on each individual test. Now, the tests that are used are very simple. You stabilize the leg like this, and then simply just hold, and then just move the lower bone forward. Now, it's very rare for somebody to come into your clinic that has 2 ACL torns. So you examine one based on the other. You get a measurement of what's normal by doing the test on the normal knee and then doing it on the involved knee. And that gives you a pretty good gauge of what's normal for that individual. That is why you need to do several tests, because some people have more flexibility than others do, especially women. Now, this right knee, I'm pushing the lower bone forward. It's stable. There's no excessive gliding forward. Now you can relax. Relaja. Now I do the same thing over here. Again, there's not excessive gliding forward. Now, mind you, this is subjective testing. It's a feel that the examiner gets in the knee. It's by no means an objective test. But once you've done it a few thousand times, you get a good understanding of what normal is. Now, obviously, Anna has no instability in this position. It seems like a normal, stable knee. Now, you're going to lay down flat, your head over here. So that test, she's negative for. But I can't rely just on that because of the position of the knee. You want to examine in different positions, because each position gives, the ACL assumes a different tension relationship within the knee joint. Now, she's normal there. Now, what I'm going to do now is I'm going to test it again on another position. Relax. Now, this one is more sensitive because you can almost hear an audible click when you do it. You position the leg just about 45 degrees of bend, and then you just give a jerk upward. I can actually feel the ligament actually tense as I jerk upward. and I can almost sense an audible click. That click is the ACL preventing me from moving this lower bone any forward, any higher forward. So there's a click here. So that tells me that the ACL in this knee is not traumatized at all, and it's not stretched. So, and if I would do it on this knee, it would be the same, I would get the same sensation. So I got 2 tests, and both tests are negative. So that pretty much gives me a 100% almost guarantee that these ACLs are healthy. Now, the third test is simply just giving a force in this direction. Now, you can see here that there's almost like an opening right here. I don't know if you can get this, Carlos, but you can see that she demonstrates some instability here. When the ACL is torn, you usually see this type of instability on this side of the knee. But since the other 2 tests on Anna's case were negative, this instability that she is demonstrating on the inside part of her knee are not a function of an ACL trauma. It's a function of her phenotype. Again, I use that word phenotype. It's the function of the structure, the form of her knee, not from the environment, but from her hereditary. She demonstrates it here on the left, and she's demonstrating it here on the right knee too. So let's come over here and let's just do this test here, just to be absolutely positive. Again, I can sense an audible click here. This ACL is intact. If this ACL would have been torn to any degree, I would not get this clicking. Now that's why I say you need to do several tests to be absolutely positively sure that her ACL is intact, because one test will not give you enough data for the practitioner or the clinician to be absolutely sure to determine whether that ACL has been stretched or torn. You need to do several tests and then combine all the data and then make your decision based on all the data that you get from several tests. In my opinion, 3 tests is more than enough. So we know that Anna's ACL is intact, and we also know that her medial compartment does demonstrate some instability, but it's not a function of the ACL tear. Now, what I'm going to do now is I'm going to show you x-rays on some knees that have had reconstructive surgery. And I'm going to show you what you need to look for in order to determine whether that surgery was done anatomically correct or incorrect, and what subsequent or what consequences exist when it is done incorrect. So what I'm going to do now is I'm going to turn off this light so you can see. Now remember about that ACL. That ACL is anatomically is positioned in an angled position. I'll show you here on the x-rays. Now, this is the first example. Now observe this. Sometimes when they do ACL reconstructions, they use biodegradable anchors. They use a biodegradable anchor. You'll see shortly what I mean by those anchors, but you can see one of the anchors right here on the femur bone. The bottom, the tibia bone, doesn't have an anchor. They used a biodegradable anchor, which means is the anchor just dissolves, but the ACL anchors itself to the native tissue. Now what I did here, you'll see it more clearly later, I outline where the tunnel where they thread the reconstructed ligament through the knee bone. Now observe how vertical this tunnel is. Look at the upper anchor over here. Very rarely would you see this anchor on the femur bone, on the upper bone, placed in an incorrect angle. Where you always see it, and most of the times, in my experience, in the majority of the ACL reconstructions, the lower anchor is the one that's placed always in a wrong anatomical position, as this one is. This tunnel is too vertical. I'll show you what a normal one looks like. And now, when they do this, the environment of the knee changes. So remember that formula, the VE, the environment changes because when they put the anchor or the reconstructed ACL in this angle, the tension of that new ligament is not what the knee evolved to be. Most of the times, there's either too much tension or not enough tension. When this anchor is vertically oriented, the tension will always be abnormal, and it will have consequences to the biomechanics of the knee joint. And you can see the consequences right here. Arthritis is starting to form here. Now, this arthritis formation here may not have been a result of this placement of the ACL reconstructed ligament, but it doesn't help prevent arthritis from materializing in the joint after the knee suffers an ACL tear, because the new tension of the new ligament is not normal. It's not normal for the phenotype of the joint itself. This is a classic example. You see this all the time. The tunnel is vertical. You'll start developing excessive amounts or accelerated amounts of degenerative changes inside the knee joint. You can see it here on this outer half of the knee, and you can see some of it on the inner half of the knee. All right, now let me show you another one. Now, here you can clearly see both anchors. They didn't use the biodegradable anchors here. Now look at this, how interesting. Again, the angles of these anchors are not normal. It's not what you want to see, but they are better than the first x-ray that I showed you. This upper anchor here is not exactly how you would like it, but the lower one is closer to true anatomical native ACL position. You can look at the angulation. Remember, the ACL, as you saw, you remember the picture, the ACL always takes an angle from the inside to the outside, just like this. That's the normal position of an ACL in a normal joint. This lower tunnel right here does have a inclination to it. It's better than the first x-rays you saw, but it's not perfect. And again, you see the x-rays over here. Degenerative wise, they're not as bad as this one. You can see the tunnel here is very vertical, and more arthritis in the knee. This tunnel here, it's more angled, more truer to the normal position of the ACL, and you don't see as much arthritic development in the knee joint itself. So this ACL reconstruction is much truer, respects more the anatomical alignment of the ACL than the first one does. Now, this ACL reconstruction was done with total biodegradable anchors. You don't see any bolts, any screws in here, but you can see the tunnel. And I'm going to outline it now. I don't know if you can see the tunnel here, but I'm going to outline it. This is the tunnel. This is the tunnel. And this is the upper tunnel right here. Remember what we said. The ACL comes from the inside and it travels upward and then attaches to the outside of the upper bone. This tunnel is much truer to normal alignment, native alignment in the ACL than the other two. And now here you have the consequences. You have a knee joint that really doesn't demonstrate any or very little arthritic changes. There's very little arthritic changes here. So the question you have to ask yourself, and the question that I ask myself all the time is, how important is the alignment post-reconstruction of the ACL for the individual, the probabilities for the individuals to develop degenerative changes in the knee itself? And I think it is very, very important, extremely important. Obviously, there's a lot of variables here that may have contributed to these knees developing arthritic changes. One individual may have been more active than the other. But irrespective of those variables that I do not know any of, you always want an ACL reconstructed to assume the normal angulation or the normal position in the knee joint, which is always an inclination from the inside out. And I think if you decide to have an ACL reconstruction or not, the tunnel position is really is subsequent to the experience of the surgeon himself. The more experienced the surgeon, the more probabilities, the more chances are that you're going to have this tunnel placed in a normal anatomical position. And of course, we can come over here. Now, the reason I thought that this volume should be dedicated to the ACL is because of all the orthopedic surgeries that exist out there. In my opinion, the ACL reconstruction is one of the more valid surgeries that an individual can have electively done once their ACL tears. Because as we spoke earlier in other volumes, instability of the joint is something that the joint cannot tolerate for too long without it developing degenerative changes. So if you're an individual that unfortunately has had their ACL torn, and you want to continue with at least as close to normal life, functioning life as possible, ACL reconstruction is one of those procedures that does have a valid use in the orthopedic domain, because it does stabilize the knee, and stability is key to a healthy joint. But you have to ask your surgeon how experienced, and you have to ask many questions. Discuss with the surgeon how much experiences they have, and even ask them to show you some post-surgical examples, and pay attention to that tunnel position. If he shows you examples and that tunnel position is not in that angled position as you see here, then it's probably time to get another orthopedic surgeon, because if he puts that tunnel in a vertically oriented position and you continue to run on it, or you continue to be excessively active on that reconstructed ACL, the tension relationship in this knee is not what it is, and you're uninvolved. So I think the lesson to take from this volume is, if you are unfortunate enough to have the ACL tear and you do decide to have it reconstructed, it's highly recommended that you ask your surgeon to show you pictures of his past surgeries and pay attention to that tunnel position. It's extremely important. If you see over and over again, if he allows you, or if you demand for him to show you the x-rays, if you see over and over again vertically oriented tunnels, pick another orthopedic surgeon. Now, hopefully this volume, you've learned a little bit about the ACL. For all those folks out there that maybe has an opinion, have had ACL reconstruction before, have had maybe even problems, or they want to share their experience, just contact us on the video. And for anybody that sees this video, thank you very much, and until next video, thank you.